Then there are two important considerations. Let's suppose if somebody is having a condition called sick day protocol. Then there comes a very big myth about SGLT2 inhibitors that there is so much of urine tract infection risk. The magic drug for diabetes. Now that's a new one, and there are so many of them now. For the last 6 to 7 years, the drug called SGLT2 inhibitors or the sodium glucose co-transporter, they have been used extensively. There have been so many myths and problems with these drugs that I think should be a clarification video that what are the realities and what are the myths. So SGLT2 inhibitors are the drugs which take the blood and they take it from the blood, glucose from the blood, and they just dump it into the urine. It's one of the simplest mechanism of actions that you can imagine. Just remove the glucose, get rid of it. Now the sodium glucose co-transporters, they are of multiple names like empagliflozin, dapagliflozin, canagliflozin. There's so many of them. But I won't be going into the details of each and everything, but I'll be talking about few things that have been highlighted in the past few years now. So the first thing is, can we use these SGLT2 inhibitors at the GFR less than 20? That means if the creatinine is just too much or the kidney dysfunction is a little too much, can we use it or not? So the answer is relatively no, but a conditional yes. If the SGLT2 inhibitors are not really in use and somebody is having a creatinine of like 4 or 5 and they're having a GFR of below 20, GFR is a test report that is given in your report, and it is basically a glomerular filtration rate estimation. And if you are below 20, you are already in CKD4 later stage, and below 15 you are in CKD5, and then you should be starting on dialysis. But even at this point in time, AV fistula and an AV excess should be considered because of the possibility of the dialysis in the future. In these cases, generally it is advisable not to start an SGLT2 inhibitor. But on the other hand, if the patient is already on one of these drugs like empagliflozin and dapagliflozin, in that case it may be permissible to continue with a lower dose of these drugs and enjoy the benefit of these drugs at the same time taking care of the diabetes. So why are we concerned about it? The thing is, these SGLT2 inhibitors, they tend to decrease the GFR when they are started in the initial few days of the treatment. And the reason for that are multiple and that are beyond the scope of this discussion, but the mild rise of serum creatinine like 10 to 20% is not an indication to stopping the SGLT2 inhibitors. Reason for that is, these drugs are so wonderful. They reduce the sodium level, excess sodium from the blood, and they get rid of it through the urine. At the same point in time, they are also getting rid of the glucose. And the research has proven that improves the sodium load, that improves the fluid overload. It's good for the heart, it's good for the kidney, and there is increased chances that your heart and kidney is going to perform well if you're already on it, and even if you're not having a chronic kidney disease or a heart disease to begin with. So it's preventing even before the start of the disease, it is helping you to stay healthy. So that's good. But in general, if you're already on it, you can continue, but this is a decision that should be done by your doctor, and of course it will be done by your doctor. But there is so much of a confusion online that I decided to make a video so that you know if some doctor is continuing with one of these drugs and you're having a low GFR, he may not be wrong. It is permissible to continue in that sense. On the other hand, there is a new question that if somebody is having an end-stage renal disease or he is on maintenance hemodialysis or peritoneal dialysis, can he or she be continued on SGLT2 inhibitors? Now that's a controversial domain, But lately, there have been so many papers that have cited that end-stage renal disease is not a complete contraindication to use of these drugs. As the mechanism suggests, there needs to be some urine output so that the glucose can be arrested from the blood and dumped into the urine. If there is total anuria and there is no urine output in an end-stage renal disease patient, then the function of these drugs is not going to be there. In that case, it's not really advisable to use these drugs, but if there is a residual renal function, it may have some utility. But that's a very controversial decision and it needs to be made by a nephrologist, not anybody else. The final thing is, let's suppose if you are having some kind of drugs to increase your urine, these are called the diuretics. In that case, the dose of those drugs needs to be reduced. Now, that how much it should be reduced, that is an art that should be exercised by your physician and not by yourself. But your diuretic dose needs to be reported to your family physician or an expert, whomever you are dealing with. And if the diuretic is already in the full dose, probably it's advisable to reduce it to some extent in order to avoid dehydration and excessive loss of water from the body. Then there are two important considerations. Let's suppose if somebody is having a sick day, there is a condition called sick day protocol. The sick day protocol is very well documented. It means if somebody is having SGLT2 inhibitors, empagliflozin, dapagliflozin, and he or she falls sick, and he or she is admitted to the hospital and needs some treatment. In that case, if the patient is too sick, it's best to stop SGLT2 inhibitors for a few days with the advice of your physician. It's not always stopped, but it can be stopped according to the sick day protocol. And that is just to help the people recover, and once they are back to their normality or the baseline, in that case it needs to be restarted. In the perioperative periods, and specifically sometimes if the patient is undergoing multiple contrast CT scans and angiographies, sometimes it is advisable for those patients to stop SGLT2 inhibitors for 1 or 2 doses, but that is not really clear how much and for how long it should be stopped. But for example, somebody is in a daycare and there is a procedure that needs to be done within a day and will be discharged in the evening. Only the morning dose of SGLT2 inhibitors is generally stopped. But in the case there is a huge surgery like cabbage, like heart bypass surgery, or any major surgery for that matter, usually SGLT2 inhibitors are stopped 1 to 2 days before and restarted after the procedure a couple of days down the line. Then there comes a very big myth about SGLT2 inhibitors, that there is so much of urine tract infection risk with dapagliflozin, empagliflozin, and cana, or you name it, all kind of SGLT2 inhibitors. The truth of the matter is, the urinary tract infection itself is not really a big deal in terms of risk. It is the mycotic infection or the fungal infection of the perineal area, which is a skin infection, which is more at risk. And if somebody is not having a mycotic infection or a skin fungal infection in the perineal area or around the urine site, in that case, he or she may not be at much risk. And there isn't any indication that for patient, just for the anticipated UTI, you should stop using SGLT2 inhibitor. But if somebody is having an uncontrolled UTI, I may not start it so that the glucose is not there in the urine and the bugs are not using it. But that's a different ball game. But the overinflated risk of UTI that is being advocated all around the online platform and the social media, there is no scientific substance to prove that. And you must be taking these decisions with the help of your physician and the specialist. There are some reports that canagliflozin and some other SGLT2 inhibitors, they are associated with some foot disease like diabetic foot and foot ulcers. But the box warning is removed lately, and generally it is not really a big problem for somebody to use SGLT2 inhibitors if he or she has a diabetic foot. But always take the consideration and the advice of your primary physician or the specialist, and he or she should be making the decision, not you. The last part is, let's suppose if somebody is having stones in the kidneys. Now, should we be dumping more of the glucose in the urine? Now, that's a very interesting question, and the actual data or the research is counterintuitive. Generally, it seems so that probably we should not be getting too much of the glucose into the urine because that may increase the chances of infection. But the reality is, it turns out that if there are more SGLT2 inhibitors used in a stone disease patient, it tends to reduce the chances of recurrent stones. So actually, it was preventing the formation of new stones. And the reason for that may be that there is too much flow of the urine and there isn't any stasis. So it's just like washing with extra water and the dust is just removed with the urine. So these are the few factors that are updated in the last few years by the element of research. I hope they will be able to answer a few of your questions, but as always, remember that these decisions are to be taken by your physician, not by you. Stay safe, stay healthy, and stay informed. Thank you.